Hey guys, in this first video, I will be going over diabetes, and I'm actually going to be going through it based on the nursing process. We're going to start with the assessment, then diagnosis, planning, interventions, and evaluation. Let me share my screen with you all. Diabetes mellitus is also known as a silent killer. Prevalence. This actually really surprised me when I first got my nursing job. 1 in 5 at least of my patients in the hospital have diabetes, whether that being type 1 or type 2. But that is a lot more than I encountered just in my daily circle. And 8.3% of the US population has diabetes. And in that diagram there, that is 1 in 11 adults. So this is what happens with diabetes. It's often referred to as a lock and a key. Insulin is the lock that allows, insulin are the keys that open the lock of the cell so that the glucose can get into the cell in order to use it for energy. So normally after we eat carbs, the body breaks down this into glucose, which the cells can use for energy. The pancreas is what secretes insulin to allow this glucose to get into the cells. And so the insulin, without the insulin, the sugar does not get broken down properly. And so this glucose is just hanging out in the bloodstream and it cannot get into the cell. With diabetes, the pancreas, his beta cells, do not produce insulin, which is type 1. Or the production is insufficient for cellular energy due to the receptors not responding properly, or there's a lot of fatty tissue, and so the insulin cannot get to those receptors to allow the glucose to get inside, which is type 2. And here's the difference side by side. Type 1 is insulin dependent or juvenile diabetes. This is actually only 5 to 10% of the population. So this is a genetic type of diabetes. There's no insulin production at all due to autoantibodies attacking the beta cells. So the pancreas no longer produces insulin. So these patients are insulin dependent and they need their insulin. It's non-reversible, and then they are at risk for diabetic ketoacidosis, which is what I will explain later. Type 2 diabetes is adult onset. There's 90 to 95% of the population. So most of our diabetics in the hospital will have type 2 diabetes. And that's often due to obesity, a sedentary lifestyle, and the cells do not accept the insulin. They are insulin resistant, and there's less insulin production as well. This is reversible. There is a triangle effect, such as with lifestyle, diet, and then medications, which are antidiabetics, and that can be in pill form. So these are not insulin dependent. Some of these patients are on insulin, some are just on these pills, or even not on any medication at all if they critique their diet and their lifestyle, which we will talk about later. And they, unlike the type 1s, have hyperosmolar hyperglycemic syndrome. And this is no ketones, which is what we will explain later as well. More on type 2. So that's a little picture there which shows all the organs that are involved. So on the left, you have the liver here, and then you have the pancreas, which secretes the insulin. The liver secretes glucagon and glucose. There are 3 metabolic defects in type 2 diabetics. First one is due with the peripheral tissue. So this is the skeletal and the adipose or the fatty tissue. They become resistant to insulin. There's decreased glucose uptake and utilization. So the glucose cannot get into the cells. The cells thinks they're starving, whereas they have all this sugar just in their body with nowhere for it to go. It often occurs long before a patient develops any symptoms because the pancreas is actually able to compensate. But eventually it begins to burn out, and then that is when they're classified as a type 2 after they do the diabetic tests. Second is with the liver. The liver increases glucose production. And so the cells are starving. The liver thinks there's no glucose, no energy. And so it's like, hey, we need to secrete more and more sugar. And so it creates an even more hyperglycemia. And then finally, of course, we have the pancreas, where there's impaired insulin secretion. The isolate cells, which are the beta cells, initially overproduce the insulin to try to compensate for the elevated blood sugars, but eventually it begins to burn out and it can no longer supply the demand that the body needs. Diagnosis, there are several different tests which determines whether or not a patient has diabetes. An actual diagnosis is called a hemoglobin A1C. An A1C measures a 3-month blood sugar average. It measures the amount of sugar that's attached to a hemoglobin. So a hemoglobin A1C over 6.5%, that is an actual diagnosis for diabetes. That means that 6.5% of the red blood cells have sugar attached to them. And so this allows doctors to even measure a diabetic's compliance with their insulin or their antidiabetics, because they're able to see that average fasting sugar over 3 months, because that's how long red blood cells live. And then there's a confirmation second A1C. A normal is less than 5.7. And anything leading up to that is pre-diabetes, and then over 6.5 or equal to gives you that diagnosis. I actually had a patient not too long ago that said she was in diabetic ketoacidosis because her boyfriend burned her insulin. Due to the A1C, that does not just happen within 3 days. So she has obviously been non-compliant with her insulin for much longer than that in order for her to become in ketoacidosis. The second test is a fasting plasma glucose. This is normally over 8 hours, and a normal is over or a normal is 70 to 99. But this number can also depend on your facility or your textbook, but that is just a rough range. Diabetics often have a fasting sugar of over 126. There's also a casual glucose, so this does not involve fasting, over 200, with classic signs of diabetes, which are the 3 Ps, and we'll discuss those within the next slide. There is a 2-hour value after a 75-gram oral glucose tolerance test. So the doctor will give you 75 grams of glucose orally and see how your body reacts. If it's over 200, 2 hours after this, which is a postprandial, you are more likely to have diabetes, and a normal is less than 140. A postprandial glucose, or after meal glucose, is one of the earliest detectable abnormalities found in diabetes. In non-diabetic patients, the plasma glucose actually peaks 1 hour after a meal, but it rarely goes over that 140. So if it's over 140, then you're starting to think that you have diabetes. And it normally returns to preprandial levels, so before meals, in about 2 to 3 hours. Signs and symptoms. The first signs and symptoms are often due to hyperglycemia, because these patients have never been diagnosed before and their bodies have been compensating, and all of a sudden it burns out and they present with the 3 Ps. This is polyuria, polydipsia, and polyphagia. Polyuria is peeing a lot, and that's due to the high osmolality in their blood. So their blood is almost like syrup because they have all that glucose just hanging out and it's not getting into the cells where it needs to go. And so they're drinking a lot to try and dilute this super concentrated blood that they have in their body. And then the kidneys try to get rid of the water and the sugar as well. So due to this, they are also really thirsty, which leads us to polydipsia. They drink a lot to try to dilute this osmolality. And finally, polyphagia, they're eating a lot because their cells think they're starving. And you treat this with insulin and antidiabetics to lower this level. Diabetic ketoacidosis, or DKA, this is only with our type 1s. The body starts to burn fats for energy and proteins as well, because the insulin's hanging out in the body, the cells think they're starving and they need something else to give them the energy they need to thrive. And so they start breaking down these fats. Ketones are actually a byproduct of fat metabolism. And so they develop a metabolic acidosis, which leads us to a high heart rate, a low blood pressure, you're dehydrated, warm, dry skin, and Kussmaul's respirations, which are really deep and rapid breathing to try to blow off all the acid that's in their body. And they often can develop a fruity odor in their pee or under their breath due to the ketones that have been produced. And you treat this with lots of fluids. The fluid will help dilute the serum and protect the blood pressure in the body from crashing any further due to the starvation. And of course, insulin therapy. They'll often start out in the ICU under an insulin drip with close monitoring and then transition to insulin pens when they get back to the floor. And too rapid replacement can actually cause a cerebral edema, which is where the brain is swelling because it's filled with all this fluid. So it's a very gradual thing and it has to be monitored very strictly. And finally, electrolytes. Potassium replacement can actually lower a blood sugar because it allows the insulin to get into the cells. And sodium bicarbonate if the acidosis is less than 7. And this is a little map that shows DKA based on all the systems. So at the top there, you have the pancreatic cells. The beta cells are being destroyed. And so there is lack of insulin, which leads to the skeletal tissue breaking down fatty acids and breaking down the muscle, which leads to hunger of the cells, polyphagia. And then finally, the liver is like, hey, I need some more energy. So you're trying to secrete more and more glucose to try to get those cells to take that up. And it's just not working. So it elevates your blood pressure. You're going into fat breakdown, leading to ketoacidosis. And finally, your poor kidneys are trying to get rid of all this extra water, all this extra sugar. And then it finally leads to volume depletion, electrolyte depletion, and then you're really thirsty to try to replenish all that the body has lost. And this is for type 2. This is basically the DKA for type 2, except there is no ketones produced. This is hyperglycemic, hyperosmolar, non-ketotic syndrome, or HHS or HHNS, whichever abbreviation you want to go with. This is a very severe hyperglycemia. So this is when the glucometer in the hospital will read high, and you have to get the lab to actually come draw an actual blood sugar to see the appropriate value. So these can be anywhere from 600 to 3,000. Which is nowhere near the amount it takes for a type 1 to develop DKA. There is no ketosis, there's no fatty breakdown, there is just a very high osmolality in the blood. So the blood is super thick and syrupy, and these patients are very dehydrated. There's often some neurological manifestations. They can get really confused, altered mental status, just shaky, and hungry. You'll treat this with rehydration as well, electrolytes, and then they will actually get insulin during this episode. And here is a map based on HHS. They have extremely high blood sugars, which leads to osmotic diuresis, which is the polyuria, which depletes the fluid volume, leading to a low sodium, low potassium, low phosphorus, leading to dehydration, and you're losing all those electrolytes, but all that sugar is still left in your body. And so they develop low blood pressures due to the depletion of the fluid volume. Your kidneys are not being perfused. They're peeing out a lot, and then they stop peeing. They have a low blood pressure. Your tissues are not getting the blood through they need. So there's increased lactic acid, and all that blood is concentrated, creating a hemoconcentration, a very thick blood leading to clots. So all of those are not good at all. That can be cause seizures, shock, coma, and death. So this just needs to be treated properly with the fluids, the insulin, and electrolytes. So here we go, signs and symptoms. We already talked about hyperglycemia being the 3 Ps, polyphagia, polyuria, and polydipsia. Hypoglycemia is actually even more dangerous because this can cause a patient to get into a coma very fast. A little acronym that I like is cold and clammy, give me some candy. So these patients are really cold, but they also may be sweating, they're fatigued, they're very weak. And this is actually not always a blood sugar less than 70, which is the textbook definition of hypoglycemia. It's actually patient dependent. So if these patients are normally used to their sugars being in the 200s, well, if they drop down to 100, they can have signs of hypoglycemia, and that needs to be addressed. Some treatment for them. So there is often the rule of 15. So 15 grams of carbs, recheck in 15 minutes. 15 grams of carbs, that's 4 ounces of juice, crackers and peanut butter, a candy bar, and offer a meal. And actually in the hospital, you would do this first, Then there is a dextrose 50 syringe. You normally give about 12.5 grams of that, and some sugar gels. All of those will help increase the blood sugar. And always recheck in less than 30 minutes. If you hit that 30-minute mark, you have fallen out of the recheck time. You treat it until it's over 70, and then you want to do a recheck in 1 hour to make sure that they do not drop again. Simple sugars like the candy and juice will raise the blood sugar faster. However, it will also cause it to be eliminated quicker and a faster drop. Complex carbs such as meals, grains, anything that's not synthetic has better blood glucose control because it takes a little bit longer for the body to eliminate that. And here is the triangle of treatment. This is for the planning and intervention part of the nursing diagnosis. There's exercise, diet, and medications. All three of these together will help these patients get under better diabetic control. We'll start with diet. So consistent carb or carb counting diet are very beneficial for both type 1s and type 2s. A single carb serving is 15 grams. So that would be 1 pack of graham crackers, a slice of bread, 3/4 cup of cereal, a very small fruit, a cup of milk, and any desserts. So I put a little chart there on the right. Any serving of these are called exchanges, and the patients can decide how much for each meal that they want. And this does not carry over to another meal, but as long as they have around 45 to 60 grams per meal based on whatever the doctor ordered, they will have better glucose control. So, for example, breakfast, if they had 45 grams, well, that would be 3 carb servings, 15 times 3. And so I would say, well, I want to do some crackers. I'll take a little cup of soup, chicken noodle soup, and I'll do a small fruit. Well, that would be your breakfast. And then you'd have to substitute your proteins and any other things around those 3 carbs. And this is actually good because a lot of these patients are like, oh, well, I cannot have that candy bar, or, oh, I can't have cake ever again. Well, you can, you just have to structure your meals around that. So if you want 2 pieces of cake, okay, have 2 pieces of cake, but then you can't have spaghetti for dinner. Exercise is super beneficial for diabetics because it allows the carbs to be used properly in the body, and it will lower your blood sugars. So best time to exercise is actually early in the morning due to your hormone levels. And it's important to check your blood sugar beforehand, during, and after, especially if you're starting to feel some symptoms of either hyper or hypoglycemia. And always have a snack handy because you never know how quickly it can drop. All right, here we go into treatment with insulin. Vials are a lot cheaper than the insulin pens. They can get a vial and a needle of insulin for $25 at Walmart, whereas like the insulin pens and Lazear and all that can get into the 100s for a box. Insulin is actually decreased by 20% inpatient a lot of times due to a more controlled diet and lack of exercise. So it's important to teach our patients that if they're on metformin at home, this will probably get discontinued, or if they may take 30 units of Lazear, they will probably get less than that while in the hospital because of the activity levels are different. We'll start with rapid acting. This is what you give right before a meal. So if you see the lunch trays or the breakfast trays coming around, you can go ahead and give this insulin. It acts really quick in 5 to 15 minutes. It often peaks in 30 minutes and will last around 2 to 5 hours. This is your Novolog, Humalog, or Lispro, Aspart, and Glulisine. This is a clear insulin. A lot of times you'll be giving a bolus meal dose based on a sliding scale. So if you have check your blood sugar before you eat and it's 150 to 200, you may give 1 unit. Or if it's 200 to 250, you may give 2 units. It just depends on what the doctor ordered for that patient. Regular insulin, you can actually give IV. It is the only insulin you can give IV. So the patients who are upstairs in the CCU for diabetic ketoacidosis and they're getting an insulin drip, they will be getting the regular insulin IV. and that is humulin or novulin that is also clear. It acts within 30 minutes, normally peaks around 2 to 4 hours, and it lasts 6 to 8 hours. Intermediate acting insulin, this is NPH. It's humulin or novulin N. This is cloudy. It acts within 1 to 2 hours, peaks in 6 to 12 hours, and lasts a lot longer. So this is for your basal all-day coverage. So a lot of patients will have a Novolog for rapid acting before your meals, and then a Levemir either once or twice a day to help control your sugar all day long, even when you're not eating. And then there's peakless. This is your Lantus and your Levemir, or your Glargine and Dedamir. They are actually clear as well, so you have to be very careful, especially drawing it from a vial, because it looks like rapid acting, but it is not. It is peakless, so there's no peak involved. It acts within 1 to 2 hours, but it lasts for over 24 hours, and this is for all-day coverage as well. And here's a little chart that I like. This shows insulin peak times. The peak time is where you're most at risk for a hypoglycemic episode. And so that yellow bar there shows the asparglucine and Lispro. That's your Humalog and Novolog. That peaks within 4 to 6 hours. So at that peak time, that is where that patient is most at risk for hypoglycemia. Then there's the regular at 6 to 8. The NPH, or the intermediate acting, at 12 to 20 hours, and then there is no peak with the Glargine or the Dedamir. Insulin administration. For the vials, you always want to do clear before cloudy, and that is when you're actually withdrawing it. So when you put the air in, put air in the cloudy, then take the needle out, put air in the clear, withdraw the cloudy. And that just allows, or it prevents the extra proteins that are in that intermediate acting insulin to mix with the rapid acting or the clear insulins. And for insulin pens, these are super convenient for patients because it's a multi-use pen, and all you do is you screw on the little lancet at the top, make sure you wipe it with alcohol. You often prime with 2 units, and that just allows the extra air and the needle to appear patent. So you'll see the insulin shoot out once you hit that button. It can go anywhere where there's fatty tissue. It can go in the abdomen, about 2 inches from the umbilicus, the thigh, the back of the arm. Make sure you clean the skin before injecting as well, and then hold it down for 5 to 10 seconds before withdrawing the needle to make sure that all that insulin is being absorbed. And lift it out of the skin, unscrew it, place it in the sharps, and it is ready for the next go round. And these are only single patient use, so please do not use them on multiple patients. They're often labeled with a patient label, and then they can be sent home with them when they are discharged. There are 2 different hypoglycemia or hyperglycemia effects phenomena that we have to explain here. So first is the Somogyi effect. This is where there is very high blood sugars in the morning. And there is 2 mechanisms where this may be the cause. First one is the Somogyi effect. This one is where there is actually too much insulin being given before bed, creating a hypoglycemia at night. And your body will try to counteract that with glucagon, epinephrine, cortisol, and growth hormone in order to increase that blood sugar. So you'll measure the blood sugar between around 2 and 4 a.m. in order to assess for hypoglycemia. And if they have a low blood sugar, then you know you're giving too much insulin before bed. So the treatment of that would be less insulin before bed, or some snacks as well. The dawn phenomenon. This is where you actually need more insulin. They are also hyperglycemic in the morning, and your counter-regulatory mechanisms are increased during the morning due to those increased cortisol levels in the morning. And these patients need more insulin to counteract. So if you check your sugar around 2 to 4 a.m. and it's high rather than low, then these patients need more insulin. Insulin pumps. These are really convenient for patients who don't want to keep picking their finger, and it allows for tighter control. It is a continuous subcutaneous infusion of rapid-acting insulin 24 hours a day, and it can be increased based on the carb intake for meals, activity, or illness. At mealtimes, the user will program a bolus dose based on the carb intake and the before meal glucose level. The site is normally changed every 2 to 3 days. These patients should check their blood sugar at least 4 times a day to make sure there's no malfunctioning of the pump, and it allows for tighter control. However, there is increased risk for diabetic ketoacidosis if it malfunctions. It is more expensive, and there is risk for infection since that needle sits in the patient's body for 2 to 3 days. Now for pills, only type 2 diabetics will get anti-diabetic pills. They often are stopped in the hospital because they can stay in the body longer, and so the doctor may switch to insulin just while inpatient in order to provide for more safer blood sugar control. Antidiabetics act by 3 mechanisms. They can increase the insulin release from the pancreas, that can allow the receptors to be more receptive, so they'll increase the uptake of the insulin, allowing the insulin to get onto those receptors and work properly, or they'll even control carb metabolism. First one, increase insulin release. So there are several classes of drugs that will allow for the pancreas to secrete more insulin. First is the meglitinides. This is repaglinide or Pranton, and natiglinide or Starlix. It's important to take these before meals, and you need to hold if a meal is skipped because it's allowing that pancreas to secrete more insulin. So if you're eating, your blood sugars will go up, and you can give them this pill before meals, and it will allow for better control. However, it's not used with patients with liver failure, and you have to be careful with hypoglycemia. So make sure you check those sugars. Second class is sulfonylureas. This is glipizide, glyburide, and glimepiride. You want to give these before meals as well, and their hypoglycemia risk is actually 5 times more likely than any of the other classes. And you also have to be careful with allergies to sulfa antibiotics. Next class is the DPP4 inhibitors, or the sitagliptin or Januvia, and saxagliptin or Onglyza. They increase the secretion hormones. So these hormones allow more insulin to be secreted into the body, and these increase those. But you need to make sure that you discontinue these drugs before any IV contrast, because that can mess with the kidneys. And exenatide, Byetta, liraglutide or Victoza, and dulaglutide or Trulicity. These are GLP-1 or incretin mimetics. Incretin is a secretion hormone, and these can actually be given in weekly injections. So it's really nice for those who don't want to keep pricking their finger or are not used to taking pills every day. However, there are side effects such as pancreatitis, but positive side effects such as weight loss, which can actually help this diabetes to be even better controlled. Antidiabetics can also increase insulin uptake, so they allow the receptors to be more sensitive to the insulin that is already in the body. These are the biguanides, which are the most common class, which is metformin and glucophage or Fortimet. They can also increase muscle sensitivity to insulin. You want to give this with meals. Side effects are several, can create some GI disturbances. However, there's no risk for hypoglycemia with these, which is super nice. You do not want to give if the creatinine is elevated, history of lactic acidosis, severe infections, heart disease, heart failure, or liver failure. Also, anybody with alcohol abuse, dehydration, or any contrast procedures can increase the risk for lactic acidosis. There are also a class of drugs, TZDs. These are the pioglitazone or Actos and rosiglitazone or Avandia. They used to be really highly used, but they are rarely used now due to risk for heart failure or impaired liver function. They decrease the insulin resistance, can cause weight gain and edema. Finally, antidiabetics can delay carb absorption. So these are acarbose, precose, and miglitol or glycet. These are alpha glucosidase inhibitors. They decrease the rate of glucose absorption and decreases the postprandial glucose. These can be given with meals. The other one is actually an amylin analog, which is a hormone that is secreted by the pancreas to allow for easier digestion. This is pramlintide and Simlin. It slows gastric emptying, so it allows the stomach and the body more time to process all these foods. However, these patients are at risk for gastroparesis, which is no movement at all of this food. There is a postprandial glucose reduced up to 3 hours. Other drugs that affect blood sugar, which people may not realize, beta blockers to lower the heart rate can actually mask the effects of hypoglycemia. So they may not have their symptoms that you're used to. So you may need to check your blood sugars more frequently. And then thiazides and loop diuretics, they increase the risk for hyperglycemia because of that potassium loss. And if you remember from before, the potassium actually allows insulin to get into the cells. So if you're losing this potassium, they're at risk for elevated blood sugars because that is not used for insulin to allow the glucose to get into the cells. Sick day teaching, it's important to check your blood sugar more frequently, especially when sick, because infection will increase your blood sugars due to the stress on the body. And so these patients may need to drink more fluids. Sometimes they may even need some sugary juices if they're not eating as much and their sugar's starting to drop. But it is important to call with diarrhea or vomiting over 6 hours, a blood glucose over 240 for 24 hours, fever over 100 for 48 hours, or if they're just unsure of how to care for themselves. I mean, it's better to be safe than sorry. And finally, we have complications. There are macrovascular, which are the bigger blood vessels in the brain. It can create strokes and cognitive changes due to that syrupy blood creating clots. In the heart, same thing. There's clotting in the heart can lead to heart attacks, congestive heart failure, coronary syndrome. And then the extremities, you can develop ulcers because these patients can develop a neuropathy where they can't even feel their feet. So it's important to make sure you educate them on proper foot care, using mirrors to look at their feet if they can't reach them themselves, allowing friends, and making sure you follow up with your doctor and inspect your feet every day before getting out of bed and right before getting back in bed for the night to make sure there's no wounds or anything stuck in their feet. Microvascular, this can affect the eyes. This is the leading cause of vision loss due to retinopathy. Your blood vessels in your retina can cause retinal detachments and clotting and allows your vision to be lost. Kidney, you can have albuminuria, which is proteins in the urine, kidney failure. And then with the nerves, like I was saying, you can develop some neuropathy. And diabetes is actually the leading cause of blindness, end-stage renal disease, and lower limb amputations not associated with trauma. So this teaching for our patients is super important in order for them to prevent any of these complications from happening. And it may increase their compliance with their medications because we could probably scare them. And finally, this is just a quick little acronym to remember what to teach our patients. It's called SURVIVE. So we want to teach a simple pathophysiology. So make sure you tell them what diabetes is, what the pancreas normally does, and how to properly treat that. You want to understand the relationships between medications, lifestyle, and diet. Encourage exercise, help them develop an exercise regimen if they need it. V is a variety of meal plans. So a lot of these patients will think they can never eat anything good anymore, but we just have to remind them that there are many good options and you can still have these desserts. You just have to make your other meals stricter controlled and just whatever you pair with those helpings. I is insulin and oral medications. Make sure they know why they're taking insulin or why they aren't taking insulin, the effects, how to properly administer it, and don't just accept a nodding of the head. Try to allow them to teach back whatever they just learned in order to assess for any confusion. And E is educate the entire family. Diabetes is a very difficult disease to live with, and it's heartbreaking when you realize that you have it. However, most of the time it is reversible. So allowing this family support can help plan meals, administer the insulin as prescribed, and encourage these patients that they can get through this. They just have to have the motivation to. All right. Thank you guys. That is it on diabetes. If you have any questions at all, just let me know. Thank you.